Great. Well, welcome everybody. It's really lovely to see you all. My name is Rob Trimble and I'm the Chief Executive of the Bromley by Bow Centre. These events, obviously, I'm sure most of you have been in these events. We've not had many events quite this big before, so it does take a little while for everybody to arrive into the room. But I think most people are here now, so we're going to kick off. As I say, really lovely to see you. We're an amazingly diverse group of people. People coming from all sorts of backgrounds. Lots of people are coming from similar contexts to the Bromley by Bow Centre, community organisations, lots of people from the health world, people coming from funders and funding backgrounds, and obviously just people who are interested in what we're up to. And I hope this morning, as we share a little bit about what we've been up to over this last year, I hope it's of interest, I hope it's informative, and I also hope that it's stimulating. I should also say, looking through the list of attendees, it's great to see some old friends and some new friends, or perhaps not to say old friends, existing friends and some new friends. So really good to welcome all of you into this environment. Of course, any of you who know the Bromley by Bow Centre will know that this is a very unnatural environment for us. We're a place-based people organisation, so doing this remotely isn't natural for us. But of course, it doesn't mean that so many more people than would normally are able to join us. So great that you've been able to come along and set aside the time. Thank you so much. We're going to reflect this morning on the last 14 months. And of course, it's been an extraordinary year for all of us, for us as individuals, for us as in terms of our families and our communities, and of course for organisations as well. And the Bromley by Bow Centre has been no exception. It's been a year, I think, which has been marked by huge anxiety, a real sense of challenge, but also a period of intense action and extraordinary achievements. And we want to share some of that this morning. So it's not been an easy time, but it has been a time when we have remolded our delivery model. We did it really this time last year. Of course, we thought at that point we were doing it for a kind of interim period, that everything would bounce back to normal. And of course, things have not bounced back to normal, I think for us, at least for two reasons. One is, of course, because the pandemic has gone on far longer than we expected it to, but also because we've learned so much and we don't want to bounce back to where we were before. Yes, we do want to go back to being a place-based organisation. We want to go back to a place where face-to-face relationships and conversations and human interactions can happen. That's fundamental to our model and our way of working and our way of thinking. But we've also learned so much about what we can do and how we can extend and improve the services that we offer as an organisation through working remotely. And we're going to share some of that with you this morning. So I hope you enjoy the presentations that are coming up. I'm delighted to say that we have an amazing home team sharing their knowledge and insight this morning. Great to have Ajit with us. Also great to have Emma and Layla and Jess and Julia and Saul, all from the home team, sharing their reflections on this last year. And also great to have Jenny from English National Opera, a really important partner with the Bromley by Bow Centre. It might seem an unusual partnership, but one that's profoundly important as we deliver our model. So delighted that Jenny could join us as well. And I'm also really pleased that Dr. Catherine Rose Stocks-Rankin has been able to join us. And Catherine Rose is going to be chairing our session this morning. So I'll hand over to her in a few minutes. Catherine Rose has been a really important person in the Bromley by Bow journey. She co-led our Unleashing Healthy Communities research program, which ran from 2016 to 2018, co-led it with Becky Seal, who I think is also on the call this morning. That piece of work has been really important. It impacts on a day-to-day basis in terms of the way that we deliver our services, but also helps and is supporting us as we deliver our evidence base and also think very clearly and more sharply, I think, about our evaluation model and our overall impact. So great to welcome Catherine Rose back. These days she's based up in Scotland and she is a Scotland director for the Dartington Service Design Lab and also co-chairs the really important national inquiry in Scotland, the Social Action Inquiry at a national level in Scotland. So great that Catherine Rose can step away from those responsibilities on a day-to-day basis and join us this morning and share this event. So Catherine Rose, thank you very much for doing that, and I'm going to hand over to you now.
Great. Thanks, Rob. Fantastic introduction. I really appreciate that. And it's so great to have a wonderful team here to share the model and to share our learning, as well as these kind of two change makers, Jenny, Malika, and Ajit, Lalani. So I'll be introducing people in turn as we come to the speakers. We'll also be taking questions throughout the event, so please do put your questions in the chat, and we'll be pulling a couple of questions after each speaker, just to kind of keep the conversation going with you, and then we've got more time at the end for questions and conversation with some of the speakers. So just a bit of housekeeping. We are recording the event, so you're welcome to keep your video on, but if you don't want to have your image in the recording, please feel free to turn your video off. We will definitely be sending you the slides that are used today and the recording of the event, so don't worry about that. And we're tweeting today, so please feel free to have a conversation on Twitter. It's #RadicalHealth, and at Bromley by Bow, we'll be tweeting and retweeting things. So that's a little bit of the housekeeping, and I think we are right on time for me to introduce Professor Ajit Lalani. So Professor Lalani is Chair of Infectious Diseases at Imperial College London, and he's also Chair of the Board of Trustees for the Bromley by Bow Centre. Professor Lalani's research addresses the world's most serious respiratory infections and spans the pathway from basic and translational science to public health and societal impact. For this, he has been recognized with multiple awards, including the Royal College of Physicians Weber Parks Medal. Ajit shares the centre's mission to improve public health and reverse health inequalities through tackling the social determinants and empowering marginalized groups. He has been the chair of the Bromley by Bow Centre for a number of years, and so we're really pleased to welcome him here today to speak.
Thanks so much, Catherine. Can you hear me okay? Yeah, good, great, thank you. Thank you, and thank you for the kind introduction. In particular for referring to me, Catherine, as a change maker. And much as I'd like to be a change maker, I think it's a wonderful term, wonderful compliment. Really, the truth is, I'm very fortunate because I spend a lot of time working with, listening to, and trying to help the real change makers, who are the people you'll be hearing from through the rest of this morning, and of course, Rob himself. I'm going to keep it fairly short, so 10 or 15 minutes I'll speak for, and really perhaps to begin with a personal note, which was, last March, when it dawned upon us as to what was about to strike around the world. And it was at that time that I was struck early on, actually on March the 12th, by COVID myself, and was ill for a full 2 weeks. And remember at that time, as I was recovering, speaking to Rob about the centre and the centre's response. And I think really what you're going to hear today is the story of how the centre coped from mid-March onwards for the last 12, 13 months now, and pointers towards how what it did and what it did so well will help to shape its future strategy and actions. And my own perspective then is one that is macro, in the sense that I study epidemiology, disease in populations at scale. Also micro, because we study the cells and the molecules that sort of result in disease, COVID, inflammatory disease, and so on. But that also, and this is actually why I study them, to study the cells and the molecules that help people to not become unwell with COVID. Because of course, although it's taken such a heavy toll of so many lives, the vast majority of people who are exposed, more than 50%, don't even get infected. They somehow resist infection. And then of those who do get infected, the majority have either symptom-free illness or minimal symptoms. And through studying, combining the macro level and the micro level in our research, we're trying to identify what are the components in the body's immune response that enable people to either resist the infection altogether, like a protective shield, or if they do get infected, to dampen the impact of the infection on the body, like a protective brake. So these are the two things we're trying to uncover. As a researcher, it perhaps won't surprise you to hear that a year on, we're still at it. working hard and have got strong clues but haven't identified it. Meanwhile, colleagues, as you know, and I'll come back to this towards the end, have taken approaches to put proteins into people, develop vaccines, get good antibody responses, and protect us against the current strain, which has been transformative. I'll come to that in just a moment. So what I wanted to talk about now, having just told you where I work at the macro and the micro level, for me, the Bromley by Bow Centre and the community is everything in between. And it's where real people live and lead their lives. And so reflecting on what's happened in communities, not just in East London, but nationally and globally, we can see that the virus has exposed very deep inequalities that were pre-existing. And I see the virus that in a way, the effect of the pandemic has been like a bright torch shining a light on these inequalities, and then cruelly, like a wedge, driving into those inequalities to make them even more large, to make the gap even larger. And this has happened at the biological level because the people who are most susceptible to severe disease and to dying from COVID are those who have diseases that are often associated with poverty and challenging life circumstances, and that includes the non-communicable diseases such as diabetes, high blood pressure, and so on. So there's that biological susceptibility. There's a demographic susceptibility, which is through people's occupations and through how they work and how they live. So we know now many occupations are much more frequently exposed. Key workers, workers in supermarkets, drivers, and so on and so forth. And then, of course, how we live, which is to do with overcrowding. So again, the poorer got infected more frequently. Then there's economic resilience. And if you have economic means, you can isolate, you can stop work, and you can live in relative comfort safely until you go back to work. If you can't do that, if you're living on a week-by-week wage to pay your bills, then to stop work for 2 weeks or 10 days of quarantine becomes a very difficult choice, and a choice that no one should really have to make. People have made those choices, and I think you'll hear more about them later this morning. And then lastly, there's social resilience and coping with the consequences of isolation, illness, and convalescence. And I think of all these 4 different types of inequalities, biological, demographic, economic, and social, I think what we're going to hear about this morning is, above all, how social resilience doesn't depend on socioeconomic wealth or attributes. That comes from the community. And so if a community really functions as a community, and that's to say it pulls together at a time of crisis, then social resilience is present, and that social resilience can make all the difference. And in a way, I'd put that to you as a little hypothesis. There am I saying, look, social resilience is one of these 4 areas I've talked about that you really can change in a community, and it really can lead to better outcomes. And you decide by the end of the morning if you think that's what happened at Bromley by Bow over the last year or not. And of course, another level of these inequalities, the 4 I mentioned, the biological, demographic, economic, and social. The biological one is also addressable, just as the social one is. And that is because these illnesses or comorbidities, as they're called, or underlying illnesses that predispose to COVID being more severe, whether it's diabetes, overweight, hypertension, heart disease, these in the last decade or 2 have shown to be reversible. They are diseases of lifestyle. They're largely reversible through improvements in one's lifestyle, and you'll be hearing from the Health Partnership and Communities Leading Change as to how the Centre has for years focused on people, on how people can improve their health, their well-being, and their resilience through non-medical means. And the non-medical means are very diverse. They're ones we know about, but the Centre helps us to put them into practice, such as the right diet, sufficient exercise. And then there are other ones that are somewhat less obvious. For example, the healing and beneficial power of the arts, put more poetically as the art of healing and the healing arts. And the Bromley by Bow Centre, as some of you will know, was founded around the arts actually, and the role of the arts. And there is an artist studio and a pottery at the heart of the centre, with artists and potters in residence. So it's very central to what we do. And you'll be hearing at the end of the program, towards the end of the program, something that is a great example. It's a jewel in the crown, as it's an example both of the power of the healing arts, or the power of the arts to heal, but also of social prescribing, because it is a social prescribing intervention that the English National Opera have started, and they're doing it very graciously in partnership with Bromley by Bow. And of course, the two organizations have worked together for several years already, with singers, professional singers from E&O coming and doing singing lessons to improve well-being amongst folk at the centre. So I won't say more about that because Jenny Malika is going to cover it very eloquently. So I think that's hopefully a bit of an introduction to the types of inequalities the pandemic has exposed and made bigger, to the ones we can do something about individually and at a community level. That's to say the biological health ones, and then the social resilience and cohesion. A bit of a flavor of the program ahead with the health partnership, the GPs talking, and then communities leading change, where you're going to hear about how actually you can own your own health and the means to sustain and improve it. And then this remarkable example of social prescription with English National Opera, the E&O Breathe program, and treatment of long COVID through that. So now I'm going to pivot for the last few minutes and say, you know, what got us out of the pandemic, and we are actually well on our way out of it in the UK now. What got us out of it in the end were two things at a national level. And those are science and the force for good. And I felt, you know, personally very proud to have been involved in the wider endeavor, to have myself worked for many years and done my PhD at the laboratory where the Oxford AstraZeneca vaccine was invented and developed. And so really the astonishing pace of science to create a solution so rapidly. And secondly, the National Health Service. Without this National Health Service, we would not have had such rapid and such equitable distribution of the vaccine. It's just phenomenal how it's managed to achieve it. And it's really a great example of what the NHS is there for. And of course, it saved so many lives in the darkest days of the first and second waves. And so this has provided the exit. We can all breathe a sigh of relief that we are well on our way out of it. And I don't think that's going to be reversed, at least not in the next months. What happens with new variants that evade vaccine immunity remains to be seen. I think they're going to come. I think they're going to be problematic. I think they're going to be more and more of them, but they're not going to get us on the back foot in the way the virus did when it first appeared. But it will be something of an ongoing guerrilla warfare for the next years. But in terms of pandemics and lockdowns, we're safe and sound out of that. So it's thanks to science, thanks to the National Health Service. Great. What do we know are that two of the areas most under threat in our society, two of our attributes that have suffered from underfunding and lack of recognition, well, it turns out it's science and the NHS. And whether or not the NHS is safe in the hands of the current government, I think had it not been for the pandemic, it would have been a big question mark as to what extent the NHS as a whole would continue to exist. But I think now, because of the pandemic, the government is going to do nothing to the NHS, if anything, fund it more, because above all, it'll be a great vote winner for the government at this stage. So actually, in a way, the point is this, that we're exiting the pandemic. That's great for everyone's health, security, and well-being. The two things that got us out of it are science and the NHS. But where has it left us? And the pandemic and its economic impact have left society worse off than before, have left the inequalities more severe than before. The middle classes, as we've heard, have had their savings swell because they've not had the opportunity to spend on discretionary items, whilst those who've lost their jobs have lost their jobs and their livelihood. So it's going to be and is cruel, and it's going to play itself out in the next months and years. But I think there's little evidence that the government has learned lessons from all of this, sadly. And I think there's little evidence it's going to do much about that. But what it has done, I think, is to grasp the narrative that it was the vaccine that got us out of it, a British vaccine, no less, the NHS that did the rollout. And in some ways, I think in people's minds, the concept of Brexit delivered by the Prime Minister is somehow associated with the fact that Britain rolled out the vaccine faster than Europe. So it's almost, I think, in many people's minds, reading as if the government saved us because it got us the vaccine, it supported the NHS to roll it out, and without Brexit, that wouldn't have been possible. So I get the feeling that's the narrative in people's minds. But in fact, the reality is very different. And the reality is that these obscene inequalities have worsened. There isn't a plan to reverse them or address them. And therefore, it seems to me that the resilience I talked about earlier and the social cohesion coming from communities is more important now than ever before. And that's why I think the Bromley by Bow Centre's response to it is an incredibly important lesson for us all when we look to the future, because we have to look to the future and we're going to have to work even harder than before to address these inequalities. And particularly as I think we're many years away from wider society and the electorate realizing that the current bandwagon or the current government or modus operandi needs a radical change. I don't think we're going to see a radical change for some time. I hope I'm wrong about that, but I doubt we'll see that in the next few years. So guess what? It's back to the grassroots. It's back to individuals, communities, how they work together. It's back to what Bromley by Bow is all about. And so I'll leave it there and hand back to Catherine as the chair. Thank you.
Thanks, Ajit. Really powerful introduction, and thank you so much for laying out the rest of the event today and introducing people so beautifully. Just as you were finishing that point about the grassroots, you know, that the radical change maybe we'll see is going to happen on the ground around us in our own communities. There's two comments here in the chat from Christine and also Simon echoing that about remembering the phenomenal response of the voluntary sector and the faith sector across the country, enabling people to access medication, food, etc. I think we've seen a lot of that, mutual aid groups, as well as more formal organizations like Bromley by Bow doing this work. So I think Ajit was finishing, I think, echoing that point, Christine and Simon. So definitely we're going to hear more of that today. There is that point about the resilience, and I think we're going to hear, I think, a little bit more both about the challenge, some of those biological, demographic, economic, and social factors that Ajit was talking about, and the kind of widening inequalities, how those are seen and experienced in primary care, and also where primary care is intervening and trying to build up that resilience, both within itself, but within the community, most importantly. So I think for me, I'm just really delighted now to introduce Dr. Saul Marmot and Dr. Julia Davis. Dr. Saul Marmot has worked at Bromley by Bow Health Partnership for 22 years and has been actively involved in the many developments between the GP practice and the centre over this time. In asking Saul for a bio, he said that this year has definitely been the most challenging of his career and has seen enormous changes in the way primary care is delivered. His interest for many years has been the interplay between mental health, physical health, and social health in each person, family, and community. So along with Saul, we've got Dr. Julia Davis, who is a GP partner at the Bromley by Bow Health Partnership and is the honorary director of the Bromley by Bow Centre. So Julia has been foundational in shaping and building the health partnership over the last 30 years, both in terms of its governance when she was chair of the partnership and deputy chief exec of the centre, but also in her day-to-day practice as a GP and as a mentor. Julia's focus for many years has been on reducing health inequalities and improving the health of populations through the provision of high-quality clinical services and addressing the wider determinants of health. So both of our next speakers, I think, combine a lot of what Ajit was talking about. And I think he was setting you up in that way of saying that he's not the change maker. It's actually both of you. And I'm sure you'll also want to hand the baton on as we go through the rest of our speakers. But I will just hand over to you now for your presentation. Thank you so much. Are you heading us up, Saul? Are you going first?
I am going first. Sorry, I had a little bit of technical difficulties. Can everybody hear me now?
Yeah, perfect.
Great. So wouldn't it be nice to get back to normal? We all remember the halcyon days before coronavirus when we had absolutely nothing to worry about at all. All our services were running smoothly and there were no difficulties. The truth of the matter is that coronavirus really has been truly terrible. But we sometimes forget how fragile we all felt beforehand. In the practice, luckily, we'd already started to panic about the state of the health of our local population and our ability to provide the sort of service that we knew that the local community really needed. So we made a lot of changes. We became very adaptable and resilient to the future, but little did we realize quite how big and nasty the future actually was going to be, and the fact that it was already breathing down our necks. So when coronavirus hit, in the practice, we had two main priorities. One of them was to protect our staff, and the other was to protect our patient population. For those of you who know the Bromley by Bow Centre and the Bromley by Bow surgery, it's a very welcoming communal space that has shared facilities and shared physical space, which is exactly what we need to provide the sort of model that we believe in at the Bromley by Bow Centre and Bromley by Bow Health, but not at all what you need when you've got a virulent global pandemic. So unfortunately, our first response was to leave the centre. And for the first 3 months of the pandemic, our teams were split across two different sites. We have a site in Stepney Green, which is one of our GP surgeries called XX Place, where our non-clinical team moved to. And we have a site at St Andrews, which fortunately is just around the corner from the Bromley by Bow Centre, where our clinical team moved to. The idea really was to give everybody a little more support, particularly the staff, to give people some days off, to give people some support. And more importantly, I suppose we were working in other teams, which were all part of Bromley by Bow Health, but teams who work a little bit differently, so that we were able to support each other emotionally and practically and learn from each other. The clinical team set up what we call clinical hubs. And I think this is one of the biggest and best things that we've learned from this. Basically, it's a large room, socially distanced, of course, where everybody, all the clinical team would sit together. So we had doctors, nurses, HCAs, pharmacists, all sitting together and listening into each other's consultations. And this is a really good way of learning, not only learning how you talk to people, the way you might say things to people, but also it was a really good support. You know, if I'd come off a particularly difficult or emotional call, I had somebody else in the room who was there to support me as well. So other ways of supporting each other is we set up huddles every single morning. Now, huddles were basically the entire team, the clinical and non-clinical team. Bearing in mind, I'm talking about the St Andrews Centre at the moment. So we were sharing this space with the whole of the St Andrews team as well. The huddles were there for us to talk about the latest guidelines, to talk about the daily struggle to get PPE. I remember one day when it was announced by Kirsty, our lead nurse, that we had 3 masks between our entire 2 clinical teams to last us all day. We were talking about our fears, risk assessments, and all the other things that had to be done. But I suppose most importantly, it was a space for us to express ourselves. You know, I remember one particularly powerful day when we talked about the Black Lives Matter movements and how issues had affected members of our staff. But I suppose the best thing about it, it was a place for stories, it was a place for jokes, and it was a place for cakes. At the time, I have to admit, looking back on it, it was actually quite exciting. This was a time when the country all felt that we were all in this together. And, you know, we would leave the building to spontaneous rounds of applause from the public. We would get cupcakes that were decorated with rainbows. We would get fruit baskets, all appearing from the local community. So this was kind of how we were trying to protect our staff. Protecting our patients was more difficult because obviously the patients are particularly vulnerable. So what we decided to do was have a situation where we were able to speak to all of our patients on the day that they needed us to. So on the day that they contacted us. You're all aware of all the modern things that seem to be very commonplace now, like telephone consultation, video consultation, photo sharing, e-consultations. Actually, these worked for us pretty well in the early days because patients didn't really want to come in and see us face to face and hang around in crowded waiting rooms, and we didn't want that either. It is important to stress that if patients really needed to see us face to face, we never shut our doors. So essentially, you know, the reason it took us a little while to adapt these new technologies is we kind of feared unequal access right from the start. But I think together as a team, we worked out a way that would work for us as a clinical team and for the patients. So we thought we'd adapted brilliantly to the future. Little did we realize that the future was actually going to be longer than 3 months. So most of our early contacts were about coronavirus and people's fears about coronavirus, and they tended to put their long-term conditions, their aches and pains and their growing anxieties on the shelf. But as you could imagine, pretty soon cracks have started to appear. You know, if your life is already pretty fragile, it doesn't take a great deal to shatter it to pieces. So sick people became much sicker. Anxious people developed depression and suicidal thoughts. And those who were socially isolated spent weeks on end without contact with another human being. I remember talking to one man in particular who, for some reason, was being very aggressive during the consultation, and I couldn't really work out why. And eventually it transpired that he was aggressive because he was scared. This man was isolating, he was shielding. And for one reason or another, he hadn't made it onto the government shielding list, and so actually had no access to food. Hadn't eaten for a whole week. So despite the fact that his neighbors and his friends were dropping little food parcels on his doorstep, he was unable to eat and was starving. So this is where our population health team and our crisis social prescribing team came into it. Once I'd made the referral, they'd sorted him out with food and packages and shielding lists within 24 hours. I'm not going to go on about them because you're going to hear all about them a lot later. So I suppose since that time, we've had some big questions to answer. What has worked well for us in those early days, and what has worked well for us since we moved back to Bromley by Bow Centre? What do we want to keep from this? And which of those things really do chime with our values as Bromley by Bow Health and the Bromley by Bow Centre? So I'd like to introduce you now to Dr. Julia Davis, who is one of the people who's helping to lead us towards whatever is waiting for us around the next corner. Julia.
Thank you, Saul. I think following on from what Saul's been saying, I think thinking back to what the last 6 months have been like, I think is worth consideration. We've experienced a second wave of COVID during this time, and from a primary care perspective, this has presented a whole new set of challenges. As Saul described, new working patterns were already established within the practice and more widely. The teams had experience of how to manage COVID, care pathways were in place, for example, around home monitoring, testing was well established, and the community, I think, is much more familiar with how to access this and understanding the nature of the symptoms and what actions they need to take. The use of technology is much more prevalent and established as well. So, for example, the e-consults, video consultations, text messaging, for example, with links to information, or the ability to send photographs. But this second wave has been set in an evolving context for us in primary care. People have delayed seeking help for routine and sometimes non-routine care. There have been significant delays at hospitals, which locally were overwhelmed, which stopped non-urgent care. But this can't be sustained long term, and these needs are emerging. Practices themselves have a huge backlog of care for long-term conditions such as diabetes, hypertension, respiratory illness, chronic kidney disease, the illnesses that put people at risk significantly from COVID. And again, the need to start addressing this is becoming increasingly urgent. The effects of the second lockdown, such as prolonged isolation, lack of work, poor financial situations, school closures, they've compounded the situation with greater levels of debt, stress, and mental health issues. For us, COVID vaccination really was the route out for this for our population. It put a huge demand on primary care who were delivering this, and again raised issues of information and access, but was critical to changing the situation locally. As Ajit so well described, the effects of the pandemic have been national and international, and the illness is a shared burden across society. But what's now so clear is it's not shared equally. A community like ours carries a disproportionate burden across both physical health outcomes and the social impact of the pandemic because of its pre-existing health and social inequalities. In the early days of COVID, groups of clinically extremely vulnerable people were identified and asked to shield. A second shielding list emerged this year, which was established through an algorithm that looked at risk associated with long-term conditions, but also looked at ethnicity and postcodes. A subsequent second cohort of shielders was identified within the local community, which gave a much clearer picture of our risk and increased our numbers fourfold. Moving forwards, our primary care response needs therefore to continue to address this directly, and this need is becoming even more urgent. For example, we need to ensure equality of access. The increasing use of digital technology as a route to accessing care is now embedded in health. But this is challenging for parts of our community, for example, with limited English or poor literacy, who have a lack of access to computers, to Wi-Fi or smartphones, or in a household within the household, parents are trying to work or study, children need computers for school or homework, and access is limited. Not having an email address was a challenge for some patients in trying to order home COVID tests, for example. So digital outreach and support programs are critical in underpinning access. We started to try to evaluate how our patients feel about current access. One of our doctors sent a text survey to a patient cohort, asking about their experiences and preferences around their contact with surgery. Now, response rates were low, and respondents appear to be both tech savvy because they were able to use the link and likely to be English speaking based on the comments they left. But even within this cohort, whilst they were very positive about their contact, over 50% still stated a preference for telephone contact with a surgery rather than e-consult. So we need to look at this with a wider population and find out what works within the different parts of our community. Importantly as well, we need equality of access to both services and information. I think the COVID pandemic and the information around COVID vaccine has highlighted, for example, that access to good quality, reliable information is really important across all sectors of the community, in particular to address the varying rates of uptake, for example, amongst different sectors of the community. The management of long-term conditions is also critical to our population, as this is what puts them significantly at risk, even in non-pandemic times, with shorter life expectancies and at younger ages developing serious medical problems. We need to continue to shift the focus from a predominantly clinical focused long-term condition service to continue to prioritise patients' individual needs and to provide long-term care. This is a subtle but important distinction between condition and care. So we're looking at better ways to identify and stratify risk and priority through more consistent data on wider determinants of health. For example, work that Saul is doing to formalise collection of information across the GP network on the wider determinants of health and medical checks for people with serious mental illness, hopefully providing a template for other conditions. This is the basis for a more nuanced approach about how care is delivered, using both clinical and population health teams at initial assessment, for example, and considering the other risks that people hold and providing services that address those directly. So, for example, services around employment and employability, access to education and training, as well as health and lifestyle advice. We also need local people to be part of the process of designing these services. We started this by developing a community advisory board with local patient representatives who can use their own knowledge and expertise to help us shape these services. This is a different approach to traditional patient participation groups. So for example, our new representatives came to our last whole practice meeting and were involved in our discussions, such as this year's monitoring requirements and our clinical and non-clinical teams' priorities for the coming year. And they will be invited to be part of interview panels for new staff members. These examples are not new ideas for us. We spent nearly 25 years as a general practice building this integrated model of care with a charity. And this has provided the foundation on which to build. The pandemic dramatically accelerated this way of working. It necessitated a much more integrated way of delivering health and wellbeing services, with a population health team across both practice and charity, with joint delivery of services such as social prescribing. It demonstrated the need to be both reactive to referral and proactive in targeting vulnerable groups. Blended health teams, including staff from other services, such as community connectors employed by mental health services, but based with us within community setting, are models that we can take forward. This is all ongoing work and needs us to have the right skill mix within the team, the right team around the table in planning services, and that's clinical, non-clinical, frontline teams and local people. It needs us to accept the willingness to challenge existing practice and to challenge ourselves, and to develop the ability to continue to adapt and change according to need. This is an ambitious agenda, I think, moving forwards. But if anything, what the last year has taught us is that the need to do it is urgent. And the only way we can move forward with this is to start that work now. I'm going to hand back to Catherine Rose now. And I'm not sure if there might be any questions for Saul and I.
Great. Thank you so much, Julia and Saul. I think there is going to be definitely a few questions. Your point about the digital divide has been getting quite a lot of chat, a lot of people echoing that. I was just going to reflect back a couple of points that struck me, and then I'll go to a question. I think what I found really important about what you said is about the way that you've shifted your practice. And just to list some of that, I think, Saul, you were talking about the support of Huddles and really thinking internally about how you support the team and support the team long term. And being really candid, I think, about fear, and you use that language of fear both in terms of like encountering the kind of first wave, both from a staff perspective, but also from people accessing the service, from patients. So making space, I think, to have those quite candid conversations, I think is a new development perhaps for the partnership. Julia, your point about long-term care, thinking about long-term care rather than just long-term conditions and that clinical model, that's an important shift. Thinking about expanding the support, of course, the partnership's done that a long time with Bromley by Bow Centre, and thinking about employability programs and health information and all of those other things that you augment the clinical care with. But then I think the community board, that's something about you're really asking those questions about what's meaningful in terms of what you provide and having that conversation really robustly with the community around you. And then expanding the team, thinking about the mix of skills that you need. I know you've been having that conversation for a long time as well, and continue to do that work. I think what strikes me and what I think we'll talk about quite a bit in the next session is that balance between reactive and proactive, and how to kind of reach out as well as just respond to the crisis. So I'm just reflecting that back because you both shared so much. I think there's probably a few questions here. Let me just see. There's a great one here. Dr. Saul or Dr. Julia, if you had just one wish to improve life for people in the local community, what would it be? That's from Janet. Saul, do you want to take us first?
I think that's the million-dollar question, really, isn't it? So thank you for that. I suppose the biggest wish is for me, is to enable our local population to have more access to things that they can help themselves with without doing it in a patronizing way. So unfortunately, you know, we all talk about empowerment and patient activation, but it's all us doing it unto them. So, you know, what we need basically is a team of people to work with who can go out into the community and help to, oh, hang on a minute, we do have that already. So fortunately, I think what we need is for the services at Bromley by Bow, the population health service and the communities driving change service to be much more active, so that the community is much more involved in their own health as well as in ours.
Nice, thanks, Saul. Julia?
Actually, it's very similar. I think what the last 30 years has taught me is that we all own health. Health isn't owned by clinicians, it's owned by all of us. And in order to deliver the sort of health that's actually health care that's meaningful to people, that directly addresses needs rather than really ticks boxes around targets or achieves clinical outcomes, needs a dialogue. And we have to think about how we have that dialogue and how we rectify the imbalance in power that exists around this, around how services are shaped, around how services are delivered, you know, and get to the core of, you know, who owns health. Well, actually, the answer is all of us. We need to do that together.
Really nice. I think there's been a number of comments. There's definitely something from Arfan Hussein here, which I think echoes that point about, you know, health means different things to different people, and to open up that space for dialogue. So the chat is heating up. I really invite people to continue that conversation. I'm seeing some really nice reflections up and down as people are reading each other's comments. So please keep that going. Julia, Saul, thank you so much for your time today. I think everyone's been really delighted by that input, and we'll move on to the next round of speakers. Thank you so much. So I'm really pleased to introduce 3 practitioners and leaders at Bromley by Bow who will speak about community-based support and the community-based support that they've been driving forward over the last year and many years before that. So we've got a few folks coming up on the screen now. So there should be 3 speakers. Yes, here we go, they're coming in. So I'll just start to do some introductions as people are landing in the Zoom frame here. So first, Emma, Owen, and Madison. Emma is the Assistant Director for Population Health at the Bromley by Bow Health Partnership. She's responsible for the non-clinical projects and programs and has particular expertise in community development and engagement. Emma's passionate about challenging inequalities in the status quo and championing change within primary care. And most recently, she's been doing that through developing the Rapid Response Social Prescribing Program and the Integrated Health and Wellbeing Team. Layla Sheree has worked at the Centre for 6 years, is based at the Bromley by Bow Centre, and has managed a number of different projects, including Capital Talent, which was an employability program, Create Your Future, which is about reducing social isolation. Layla also has a passion for roles which allow her to amplify the voices of those that are underrepresented, and she's done that most recently through managing the social prescribing program at the Centre. And then finally, Jess Walker is the project manager for Communities Driving Change, which is a program that supports resident-led health and wellbeing projects in the northeast of Tower Hamlets. And Jess has a background in community organizing. So I'll hand over to the 3 of you to take us through Communities Leading Change. Thank you.
Thank you so much, Catherine Rose, and also thank you to all of the speakers that have spoken so far. It's kind of left me feeling equally emotional and hopeful for the future. So thank you for teeing us up so nicely. I'll sort of reiterate a lot of what was mentioned in the last sort of talk by Dr. Julia and Dr. Saul, who I'm really pleased to be able to say that I work closely alongside. So it's kind of a continuation and a fair bit of overlap in some of the examples that we would like to give. So I suppose for the 3 of us, the context in which we were working before is, as has been mentioned, a really deep understanding of the inequalities that our communities and people within it live with every single day. So the pandemic didn't really create a new set of circumstances for us. It just, as has already been mentioned, in several ways exacerbated those that were already in existence. We've tried for many years to create sort of strategy documents and joint ways of working to address these inequalities. And so we do have, I'm proud to say, yeah, we do have really good and strong working relationships on the ground in a number of different ways. It's quite, yeah, an interchange of different working relationships and projects and teams. But I suppose when the pandemic hit, we didn't really know what to do, to be honest. It was a shock to the system for all of us, and it was really a challenging time to be able to think about what to do. However, I think the foundations that we had meant that there was a lot of trust between our services, so we were able to do things that perhaps are typically impossible between primary and voluntary sector organisations, and even in between teams themselves. So I think that trust really took us a long way. We also acted intuitively. I mean, that sounds like a posh way of saying we winged it for a little bit until we worked out what stuck, but we really did sort of act on our gut and really kind of brought that understanding of what the community needs into practice. So I think a lot of the time we can question, you know, what is it that the community needs, but honestly, we really do know and have an intimate understanding of what works for our communities. And I think finally we responded quickly. So because of all of these things that were already in place and the infrastructure that already existed, it meant that we were able to mobilize incredibly quickly, and we were able to put support in place that meant that we were able to increase the capacity of our teams and reach a lot more people a lot more quickly because of the way that we were working together. So with that, I'll hand over to Layla to tell us a bit more about what we actually did in practice.
What we did. Thanks, Emma. So just going back briefly to before the pandemic, our social prescribing service was already delivering sort of non-medical support to patients in our local primary care network to sort of help address the health inequalities and social determinants of health, but also address the life problems that people were experiencing, such as housing issues and money worries and weight management and health and mental health and all these things that we were supporting people with. And when the pandemic hit, like every other service, I think, we saw a huge increase in the number of referrals coming into social prescribing. We were seeing pandemic-related referrals for those that were shielding and that were vulnerable, but we were also getting our general social prescribing referrals as well. So as a team across the health partnership and the charity, we thought it would be a good way to sort of address the urgent needs of the community by setting up a separate patient pathway. And Emma's, I think, briefly mentioned rapid social prescribing or crisis social prescribing. We changed the name halfway through. It's now rapid. But the idea of rapid social prescribing was for us to really focus on those urgent needs, the people that needed a quicker turnaround of support. And we were able to recruit a rapid social prescribing link worker who would contact people within 2 days and provide them with and connect them to essential services that they needed at the time, which were services like food banks and social welfare services, domestic violence organisations, and a whole host of referral organisations. A lot of the needs that we were seeing, no surprise, as Emma mentioned again, and everybody else has mentioned, these health inequalities existed, but they were hugely exacerbated by the pandemic. We saw job insecurity, we saw issues around social welfare, issues around housing, benefits advice, mental health, isolation. And so there was a real need for us to separate what we were doing in the general social prescribing service and what we were doing that was more sort of pandemic urgent needs related. But sometimes as well, the rapid social prescribers were also just providing a conversation and creating a sort of open space for people to kind of address some of the pandemic related anxieties and worries that people were having. So it wasn't always an onward referral. Sometimes it was just a virtual friendly face and a conversation. I think somebody mentioned in the chat, a couple of people mentioned actually, the importance of the voluntary sector and community-led organisations. And I actually put that in my notes when we were deciding to present. I'm not just saying it because I work for a charity organisation, But I think, you know, that the role of the voluntary sector organisations played such a crucial part of that social prescription. You know, without social prescription, what is social prescribing? It's such an important element of that support that we're providing. And so we relied very heavily on the voluntary faith sector organisations, and in particular grassroots-led community organisations such as mutual aid groups, that we know are often doing that without any funding, and doing it for free. And so I think for me it was so wonderful to just kind of experience the human and the community spirit of people just taking control and helping each other out. And I think that was something that was so amazing to see. And I know that Jess is going to talk a bit more about kind of the proactive work that we've done. But also as well, I'm quite mindful that, you know, as much as an integrated team, we responded to urgent needs. This was happening across Tower Hamlets, across London, and across, you know, all parts of the country where social prescribing schemes and link workers were doing similar work, you know, supporting people that were shielding, that were vulnerable, and connecting them to really urgent and essential services. I think the only difference with us on reflection was that because we were able to kind of collaborate and integrate our services, it meant that we were able to provide a separate piece of support for people that needed urgent care. And that meant that we didn't have to compromise our longer term traditional social prescribing service. So we were still able to provide that longer journey where we were able to kind of build people's resilience and confidence and be able to get them to unearth other issues that they've been dealing with. I think Jenny is going to speak a bit about the arts, so I'll let her do that. But in terms of social prescribing, I've got to say that we found when it came to onward referrals, the arts again as well played a huge role in the kinds of provisions that we were offering people, especially those that found themselves in situations where they were on their own and they were shielding and they were dealing with isolations. We were able to kind of connect people to really some really lovely projects such as, you know, photography groups and art groups and drama and all of that, and people were able to kind of capture their thoughts and feelings and their experiences of lockdown through arts. So yeah, I'm really excited to hear what Jenny has to say, but I just kind of make a nod to social prescribing and arts, and I'll let Jess talk now.
Thanks, Layla. So to pick up from some of the questions around digital inclusion, communities driving change, we found ourselves at the beginning of the pandemic being forced to kind of focus on our remote delivery, being able to work primarily with people who had like some level of access to digital, or had a kind of starting level where they could build their competencies. So this meant that it was kind of difficult to do outreach. But what working together with Emma's team, the population health team, and the social prescribing team meant was that we were able to reach these people through the old-fashioned telephone. So what we did was we worked together to make proactive wellbeing calls to patients who hadn't requested these calls. And we found we were reaching people who the Health Partnership and the Bromley by Bow Centre hadn't engaged with before. So we found that 80% of the people we'd spoke to were interacting with our services for the first time, and that same group of people also didn't have any support in place. So what we learned from this was that many of the people who we supported were not those who would have been identified as vulnerable or at risk, but proactive engagement revealed some acute needs that had been onset by the pandemic, such as recent unemployment, food scarcity. So next I want to talk a bit about our work around connecting people. So rather than relying just on referrals to services, we became more conversant with connecting people in similar situations to each other. This, we think, has resulted in lasting feelings of mutual support and neighbourliness. An example I can give you is a woman we worked with in Communities Driving Change. So when the pandemic began, she was living with her 4-year-old son, and it was around the time where there was a lot of food scarcity. I don't know if people remember the empty shelves in the shops, bulk buying. Unfortunately, her son began to show COVID symptoms, so they had to self-isolate. This woman was in an impossible situation because she was running out of food, and she didn't have a family nearby or a decent support network. She'd actually only just started engaging with Communities Driving Change in January 2020. So courageously, she shared her situation with one of the community coordinators who had been supporting an active group of women around Bow, and a call out was put on the WhatsApp group. One of the women in this group works at a local supermarket, so she was able to set aside some food, and there was this real teamwork together where another couple of women agreed to deliver the food to this woman's doorstep. This allowed mother and son to self-isolate and recover well. She, as you can imagine, said that this support was so valuable and that she would never forget it. So I think what we can learn from this is that the work of network building it's chronically undervalued, and we only really see the true value of it when we desperately need it. Now I want to just quickly tell you a bit about kind of working in a community health project during a public health crisis, which was certainly interesting. I can relate to some of the intuitive, winging it, kind of learning on the go. But I think one of the things that we also learn at Communities Driving Change is that local knowledge is just really important. So unfortunately, there was a local outbreak on one of the estates we work in. There was an emergency local outbreak meeting to plan the response that drew together many stakeholders, including Public Health England. So it was amazing because the team of community coordinators were able to share really important information that informed the public health strategy to control this outbreak. So at times of crisis, it's this on the ground insight that's really, really important. And that can only really be gained through like longer term investment in relationship and network building. I'm just going to pass over to Emma.
Yes, thank you, Jess, for and Layla also for those amazing examples of kind of how we worked and what we did. One of the other things that we implemented quite early on, and it's maybe the duller side of all that was happening, but it was really around kind of sharing data and capturing some kind of outcomes along the way. So I guess it was a real moment in time, and we wanted to make sure that we were capturing what was happening in a real-time way. So we actually implemented weekly data reviews, which sound very dry, but actually they served as a reflective opportunity for us to really think about what was changing it's hard to imagine actually how quickly things were changing at the height of the pandemic, but it was really important for us as a team to be able to think about what was happening and also understand what the gaps were potentially in service provision. So based on what the community was saying and based on these new people that we were engaging with, actually what were the gaps and where were we perhaps not delivering services. An example of how this worked well was a lot was coming through strongly, and I know again we've seen this a lot in the chat, was around children and young people. So this was at a time where homeschooling was the norm, and family poverty was at an all-time high. So we partnered with Save the Children UK, and we were able to we were able to administer close to £20,000 worth of grants to families in the space of about 6 months. And I think it just goes to show the real value of being able to, again, be responsive in a material way to some of the issues that were kind of emerging in the local community. Again, not new issues, but it felt good to be able to respond quickly and to partner quickly with an organisation that had the means to be able to support in that situation. So I will pass back to Layla and Jess to share quickly about what's next for us as a integrated team.
So yeah, with all of this learning, there's no way we're going to stop working together at this point. So we're committed to continue that. Regarding community engagement, capacity building at grassroots level is really important. We need more of it. But it's also not enough. We also need GP practices to transform the way they're working too, in order to foster and build radical community-led activities that can support healthy communities. The vision is that we relate to people as agents of change rather than clients. And an example of the work we're doing together is the community advisory boards, who have an explicit focus on working with GP practices to improve the way they're supporting local communities. Our plans about social prescribing, Layla.
Oh yes, so I guess it goes back to the kind of success that we carried out with the wellbeing calls. I guess giving us an experience of really interacting and engaging with people who hadn't really engaged with the services. I think traditionally we've always received referrals from primary care into social prescribing, and as much as we really value that, and that will continue, I think we need to expand who is accessing the service and who has knowledge of the service as well. And that means as social prescribers is going out into the communities and proactively engaging with the community and going where the community is, you know, be that schools, be that housing associations, and be that, you know, children's centres. It's about really expanding our reach and raising the profile of social prescribing. We can't always guarantee that somebody is going to go to their GP or visit their practice, and so we need to be engaging with those people that are not. And I think that's one of our priorities moving forward, and to continue working in this integrated way. And I know that Jess, we had a conversation about, like, it's quite hard sometimes when you're in the work to see, you know, what benefit you're having or the impact. But I guess the collaboration that we have, or all of the pieces that our services provide a really crucial part of the journey for the full journey of that person. So we're able to capture and engage people at a point of crisis, where we're able to kind of quickly get in and engage with some of their most kind of like their most sort of urgent needs. And then we're able to kind of move them along to more longer term social prescribing, where we're able to give them longer term emotional support, build their resilience and their confidence. And the main aim, I guess, is to kind of create citizens of their own community. And the work that Jess is doing with CDC in community development, the idea is that the people that we support along that journey are then able to become active members of their community and invest in their community, and hopefully along the way be able to share the knowledge that they've gained along that journey and be able to help another person that may be coming to us at a point of crisis with the same issues and challenges that they had.
Definitely. And we think that less investment in community engagement means that people may have to return into social prescribing services or rapid response for support. Briefly to mention that Communities Driving Change funding comes to an end after 4 years, and we've achieved some brilliant outcomes during that time, including supporting 20 resident-led health and wellbeing projects to be developed, and they're at risk of ending when the funding does. So I just wanted to point out that I think we can have a brilliant functioning population health team, rapid response social prescribing and general social prescribing services, but we need this to be supported by both by a well-connected and resourced referral network in the voluntary sector, but also by longer term investment in community capacity building and engagement surrounding GP practices. I'm going to pass over to Catherine Rose.
Great. Fantastic, you three. This has been really fascinating conversation, and well done. I think signaling the integration as you hand back and forth to each other. I suppose some reflections for me is, there was a phrase in the early days of Bromley by Bow, only connect. And I come back to that because I think there is so much about the model that is about connection, but the work of connection, I think that was your point, Jess, that it's undervalued, that network building. And I think anybody in practice knows that, you can be siloed, even in a model like Bromley by Bow that really espouses the value of connection. You can still be working on your project, or you can be working in the health partnership and not see some of the things that are happening in the center. And what the three of you have done is really brought that to life in terms of how you have to work very deliberately together and take risks. So I think some of the conversation there about, data security and, how to manage that, Emma has responded in the comments that people want to check about how you find nimble ways very quickly, because the risk of doing nothing is greater really than the risk of doing something. I think too, just reflecting back some of the other things you've said, everybody has networks. And so the more work you put into integrating yourselves, the better able you were to connect with some of those other community groups, which is what Layla was talking about, that are out there doing work, also perhaps in quite a fragile or unfunded way. But between the three of you, you managed to find different ways to connect into those resources. And then that kind of old school using telephones, some of the ways that the health partnership works is to pick up the phone and call people, and people call them. And so having that resource there in terms of your team, really powerful. We're running a little bit short of time, but I suppose I was just going to say one thing in terms of people who've asked questions. We do have time at the end, so if we haven't got to your question yet, we will at the end. And just maybe a final reflection, there's been some discussion about trust, and I just wondered if any of you had any final reflections on that kind of balancing of risk and trust.
I can maybe share, because I think a big part of this was kind of inviting and opening up access to kind of what is usually kind of lock and key primary care information. And I think that it honestly was like a scary moment in time, because it's something that we have not really done before. But I think as a result of firm working relationships, and also the backing of the GP practice and kind of senior managers, really made it possible that even if something went wrong, that actually we had the appropriate safety nets in place, and we had the appropriate kind of governance to be able to cover our backs in that sense. And I think also the trust of the practitioners as well. So Jess and team who came on stream first, actually, I know their work, and I know that they are just brilliant with working with their community. So actually there wasn't a doubt that they wouldn't be able to support people. It was more just kind of getting around the usual data protection stuff. But actually, once we got going, it was pretty simple. Everything was very visible, and it really did take that kind of trust. I also think a reflection from one of the local area coordinators, actually, the trust is built when it also makes sense to the person delivering the work. So oftentimes you get a directive from somewhere above to kind of deliver a piece of work, and it all feels very elusive and hard to kind of grasp. But I think because everybody was so involved in each decision along the way, actually there was mutual trust. People knew why they were being asked to do what they were doing, but also there was full trust that people would kind of value and respect the sort of task that they'd been given. So I think it worked, yeah, both and always.
Amazing. Thank you, Emma. I think we'll close there so that we can move on to Jenny Malika next, and then we'll have you back at the end for some Q&A. So thank you very much, Jess, Layla, Emma, fantastic. So I'm just really delighted now as we bring Jenny up on screen to introduce Jenny Malika, who is the Director of Strategy, Learning and Participation at the ENO. So since joining in 2020, Jenny has developed a range of new programs and initiatives, including the award-winning ENO Breathe, which she will be talking to us about today. Prior to that, Jenny was the Director of Creative Learning at the Barbican and Guildhall School of Music and Drama, where she spent 10 years working on a range of participatory arts programs. And a particular highlight for her includes launching the London Training Centre for the world's first disabled-led youth orchestra, the National Open Youth Orchestra. And I suppose the link here, Jenny, as we lead to your presentation, where you're kind of bringing us home here, there's been a lot of discussion about trust and resilience. There's also been conversations about risk, both in terms of the risk that we might have biologically, socially, economically, but also the risk that we take in our practice as we try to kind of make things more equitable. And I have a feeling that sorting out the kind of balancing act of trust and resilience is something that's really core probably to your practice as an artist and as a leader. So I'll hand over to you for your presentation. Thank you so much.
Thank you so much, Catherine Rose. It's an absolute privilege to be here this morning, and such a pleasure to hear from the brilliant team at Bromley by Bow. As has been mentioned, the ENO and Bromley by Bow have a deep and long-standing friendship, having collaborated for many years now on a range of creative projects. So it's a real privilege to be here this morning. Just before I start, I want to just take a moment for us all to just pause in our busy days and, hopefully Wi-Fi permitting, just enjoy a short musical moment from the ENO. So if it works, hopefully it will, for the next 2 minutes, just take a moment to, you can either watch this or just close your eyes and listen, and then we'll regroup afterwards. I hope everyone could hear that okay. That was Evening Prayer, which is a lullaby from the opera Hansel and Gretel, and it was performed by the ENO exclusively for participants on our ENO Breathe programme. And whether or not you've heard that lullaby before, the universality of lullabies is undeniable. It's instinctive for us to sing to our children. And lullabies play a central role on the ENO Breathe programme, which is an integrated social prescribing programme of singing, breathing and wellbeing that we developed at the ENO in partnership with the team, the brilliant respiratory team at Imperial College Healthcare NHS Trust, which with the aim to provide crucial support for people recovering from COVID-19. And over the course of the 6-week online programme, we mirror breathing techniques used in the training of opera singers to support people to manage, and in particular, importantly, to self-manage symptoms of breathlessness and associated anxiety post-COVID. And crucially, we all learn lullabies together. We learn lullabies from around the world, and we learn lullabies from famous operas. And we chose lullabies because they cross cultural boundaries, they're universal in their appeal, and they sit very well and very comfortably for non-specialist singers, which is really important on a programme like ENO Breathe, where many people who do the programme may feel very ambivalent about singing and not feel that it's something, or may feel very anxious about their physiological capability to sing because of breathlessness. So that's just a bit of an introduction to the ENO Breathe programme. And just to give some context, when I started at ENO last June, it was mid-pandemic. And as has been the case for so many arts organisations, COVID has been a time that's really invited the ENO to think quite existentially about its mission and its purpose and its role beyond the stage. And fortunately at ENO, we have had a long-standing history of working in the community and outside of the walls of our home, the London Coliseum, including our long-standing relationship with Bromley by Bow Community Centre. And this work beyond the stage is in our DNA. It's right there in our socially driven roots of our founder, Lillian Bayliss. And broadly, in my role, what I'm very interested in is revisiting those socially driven roots and exploring what our social and civic purpose means as an arts organisation today. And that invites us to think about new ways in which we connect opera and the ENO with people and communities locally and nationally in ways that are relevant and meaningful and that matter to them. And it was at that same time back last June when I started that we were brilliantly fortunate to be consulting with some leading GPs and medics in the field of health and social prescribing, including Sir Sam Everington and Professor Ajit Lalani here on the call, around the useful role that ENO could play within the context of the pandemic. And at that time, back last June, conversations about long COVID were becoming very prevalent and recognised, particularly those symptoms of breathlessness and associated anxiety that people were still experiencing some 8 to 12 weeks post-COVID. And quite quickly, we had a hypothesis that as an opera company, we might have the skills and the expertise to offer a useful and rapid solution to this problem. After all, working with breath and finding emotional connection is at the heart of opera. So we set about to develop a non-clinical, non-medical pathway for people suffering with those long COVID symptoms. And at that same time, we were very fortunate to have an existing relationship with the team at Imperial College Healthcare Trust, because our fantastic costume department had been making scrubs and PPE for the frontline workers there. And we were able to develop a partnership with the respiratory team. And that was something I really wanted to touch on that I think has come through today's presentations a great deal, is the notion of collaboration. And what I wanted to say is that I am only one small part of a big story with ENO Breathe. And there are so many people who have been involved in its genesis and development. One of whom critically is Dr. Sarah Elkin, who's the respiratory lead at Imperial College, who couldn't be with me this morning. But the development of ENO Breathe is totally dependent on a kind of three-way triangular relationship between the ENO as an arts organisation, with our learning and vocal expertise, Imperial with their respiratory expertise, and with the patient themselves, who've continued to consult and feed back to us on this programme in a way that's enabled us to iteratively refine and shape and develop the programme as we go. So it's a constant process of co-creation and co-development, bringing together medical and musical expertise and feedback from participants. I think another thing that's very important for us with ENO Breathe that I think we've talked about a lot in this sessions today is something that's taken us out of our comfort zone with ENO Breathe, is that most of our work, our learning and participation work, very much as links with Bromley by Bow here, is rooted in a sense of geography and place. And what's been different about ENO Breathe is that community is very much defined not by geography, but by COVID itself. And the community that we work with is broadly defined by long COVID assessment centres across the country. So by its very nature with ENO Breathe, it's moved from a small trial to a national rollout with long COVID assessment centres now working in 30 NHS long COVID assessment centres across the country. It's a social prescription through secondary care in which long COVID assessment centres medically assess suitability of patients for the programme and recommend them onto it through a process of self-referral. So this is something that's engaged us in a lot of discussion and exploration around how social prescribing works when it's needed in a fairly rapid fire interventional way, but actually needs to be mobilised very quickly from the local to the national. Something that's very central to us in ENO Breathe that I think runs through today's conversations as well is about the notion of something that's very human-centred. So even though we're currently working with several hundred patients on ENO Breathe, so patients take part in a 6-week programme in groups of 20 on the programme on Zoom, but actually we have several groups running throughout the day, every day. Every patient receives a one-to-one from our ENO Breathe team. They receive physical welcome packs. And what's really important for us is that sets the tone, that the relationship with the participant is one that's personalised and human. And I think that really has come through in all of the discussion so far today, that we treat people as individuals, not as patients, and that ENO Breathe is about demedicalising well-being. So when people take part in arts and culture on social prescription, I think a fundamental difference is that we're speaking to the whole person. We are supporting the health in people, the creativity in people, not the pathology. And the arts can speak to that healthy entity. And that's something that's inevitably uplifting and joyful. When you take part in ENO Breathe, you don't take part as a patient, but as a participant and as an artist. And that personalized human-centered relationship really reframes the relationship, and I think is infinitely something that's more empowering for the participant. Something that's really important about those one-to-ones at the beginning as well is that they set a clear sense of expectation for the participant on what to expect, and crucially we provide a lot of support at that juncture for people who might have concerns or digital access issues or may never have used technology before. So what we've learned so far with ENO Breathe is that we ran a pilot for the programme in autumn last year with a highly diverse cohort in a wide range of ages. 25% of the group, for them, English was not their first language, and I think about 20% of the group expressed a real concern about singing. And that's been something that's really interesting for us, the sense of, is this for me? But actually what was fascinating about the programme, and I think part of this has come through the very personalised work by our really experienced team, is that attendance on the programme and retention has been really high. And then using validated metrics for patient self-assessments pre and post programme, patients reported positive change. So 90% of people who took part reported improvement in breathlessness, 91% reported a reduction in anxiety. And most importantly, and I think what relates to conversations today, the whole group said that they would continue to use the techniques from ENO Breathe post-programme. And that's vital to us because the focus of the programme is about empowering the patient. So what we've really learned through the programme is that those feelings of breathlessness that many people are experiencing with long COVID, that feeling of feeling out of control with your breathing can actually also escalate to a sense of feeling a bit out of control in life. And actually what we're trying to do is empower people with tools and techniques that they can use in their own time in their everyday lives that put them in the driving seat with their breathing. And that is key to ENO Breathe. It's about putting people in the driving seat with their own health. There's a wonderful example for me that stood out where a particular patient spoke about regularly waking up in the night gasping for air, and that being a source of high anxiety for her, very understandably so. And after a few sessions of the ENO Breathe programme, she talked about waking in the middle of the night and being able to draw upon a particular exercise we use in the programme where we count back from 10 with our breathing. And in doing so, not only being able to regulate and calm her breathing, but also to be able to calm herself down to a point where she was able to get back to sleep. And that's what we're interested in, is that the usability of the exercises that we do for people to really increase and really increasing their confidence levels in managing their own symptoms. Looking ahead, another thing that I think is very important with E&O Breathe that's come through in the conversations today is about emotional connection. So many of the people in the E&O Breathe groups have been through some very similar traumatic experiences. We have a high number of people who on the programme who've been in intensive care. Many of the people on the programme that we're seeing at the moment have had long COVID symptoms as far back as last March and have felt quite alone with their symptoms, quite unseen and a bit unheard. And that comes through a lot in the in patient feedback in terms of how they've been feeling in the lead up to the programme. And I think there's something about being in a shared space with other people who have been through a similar experience to you, that collective experience through the creative process that normalizes what people have been through. And many patients have spoken in patient focus groups about feeling a greater sense of confidence to get back out in society again post-programme and feeling a lot less alone with how they feel. So as we look ahead for E&O Breathe, we're currently working with up to 1,000 patients in this current phase with 30 NHS long COVID centres across England, with the aim of getting people back to wellness and accelerating their recovery post-COVID. And we're also in the process of a randomised control trial with the research team at Imperial, trying to continue to build the evidence base for the programme. But importantly, what I'm very interested in is how this collaboration changes E&O and changes the partners that we work with. And I think it's about shared resilience, because what we hope is that it's building the resilience of the people who come through the programme, that it's supporting them in their health and well-being, but it's also built our resilience as a company. Does this enable us to think about how our art form has an instrumental role to play in health and well-being, and how even at the darkest times, the arts find new ways to adapt and give hope and connection to people. And it's made us think differently about how we measure and articulate the value and impact of the arts. And for our partners, we hope that it's enabled us to start a long-term conversation about how we can explore the power of the arts in new and different ways to heal, to unite and give agency to the stakeholders and communities that we work with. It's what we want to be at the E&O, as with many arts organisations, is a living resource for GPs, link workers and communities, and we're here to partner and collaborate with you. And certainly for the E&O Breathe is the beginning of what we hope is a range of work that we're looking to develop in social prescribing, very much so to continue working with our fantastic partners here today, Bromley by Bow Community Centre, who for us, in what they've illuminated on today and continue to show us, are leading and pioneering in this field. So I think that's all from me today. I don't think I'm going to show my film, Catherine Rose, because I think we're a bit tight for time and I want there to be time for questions. But it's a pleasure to be being with you here this morning. Thank you very much.
Thanks, Jenny. Really fantastic presentation. There was a question actually that came earlier in the chat that we just thought we'd pose to you. It's about the human voice. So Susan Room asked, what has the pandemic taught us about, or taught you about, the value of the human voice? And I was actually posed to Saul and Julia, I think because of the community connections there, but it's so perfect for you.
It's absolutely perfect. I think what's very interesting, actually, when I look at the thread that runs through all of the COVID response programs that we've run in our learning and participation program during COVID, everything has had a thread that's run through it that's been about the power of the human voice, whether that is from sense of breath and breathing and that sense of giving agency through finding connecting with our breathing again, to giving a creative, sort of empowering voice, creative voices in the community and with participants. And that's run through a lot of our work with community partners and young people. The human voice is something that is central to what we're doing with our learning and participation work, and is fundamental, I think, to the sense of giving agency and power back to the people that we work with.
Perfect. Thank you, Jenny. That was just such a lovely conclusion. So yeah, I think we'll move on to the kind of final remarks from Rob and I, and then Jenny will have you back hopefully for the final questions. Thank you.
Great, thank you, Jenny. That was fantastic. I should also say it's great to have Dr. Harry Brunje from the English National Opera, the chair of the English National Opera, with us this morning, and also Tanya from Jenny's team. So welcome to all of you, and thank you very much for your contribution. I'd kind of jotted down a few thoughts that I was going to share, and to be honest, just reading the chat is just filled my brain with so many different thoughts and angles, and it's been a really rich chat, and we can't really do it justice in the time we have available, but so many themes which I find very stimulating and indeed very challenging. And I suppose this little section I had in mind was really focused on trying to explain how difficult this all is, which might seem a strange place to end up, but I think it is echoed actually by so many of the contributions in the chat. I have been around for an awful long time. I think I've been around Bromley by Bow for 34 years. I've started off as a volunteer, and I've ended up as the chief executive of the centre, but I've seen a lot of change around us. We've seen numerous reorganisations of the health system. We've seen the reorganisation of local services. We've seen, can't quite work it out, I think 6 governments come and go in the time in 3 decades that we've been engaging in what we've been doing. And actually it's now, I think 24 years since we opened a Healthy Living Centre, the first of its kind in the country. The first health centre in Britain to be owned by a community charity and rented back to the state, back to the NHS, a really dynamic model. But actually, if I'm being really honest, I think it would be more difficult to do that today than it was 24 years ago. And I think that does echo some of the things that people have been saying in the chat. It is incredibly difficult. We're doing life-saving work. I think that's been demonstrated this morning. I think it was Jess who said that the rapid social response work we've done over the last 12 months has targeted a whole range of new people. 80% of the people that we're connecting with are people that we've never connected with before, and we've been around for 3 decades. Can you imagine the level of need that goes so deep within our community? And as Jess also said, we're now facing a crisis in the very project that she leads, Communities Driving Change, because despite its successes, there's just not enough money to go around, and that project looks as though it might come to an end in the autumn. And that could be repeated many times over. Many of you are from different parts of the country, and I'm sure your reflections would be the same. And as we focus on, I think somebody mentioned, I think it was Ariane, the idea of making sure that we're focused on the whole life cycle, the human life cycle from preconception all the way through to death, then of course, going back to what Ajit said at the beginning, the resources are incredibly tight. They're just not there at all. And I think so much of what we do is more difficult now than it was many, many years ago. It feels to me that often, in fact, nearly all the time, we are swimming upstream, or whatever metaphor you choose, tacking into the wind. We're kind of picking off policies and funding streams as we go along. And as a community organisation, a grassroots community charity, I think currently we have an excess of 60 different funding streams. Very few of them have any longevity whatsoever. 1 or 2 year contracts, sometimes renewed, like the Communities Driving Change contract for 4 years, but actually very little sustainable income. And we're not a government funded organisation like many of the community sector organisations represented in this call today. There is no anchor funding. Perhaps one day, Ajit was doubtful as to whether that one day will be anytime soon. And I don't think it will be anytime soon, but one day we might be funded in the same way as the NHS is funded. Not that the NHS is well funded, but nonetheless, the community sector doesn't have reliable income in the way that other bits of the public sector has. Yet we know from the presentations this morning, from what people are saying in the chat, it is the most creative part of our whole delivery sits within the community sector. It is a bit that's most closely connected with real people, real communities, and real lives. And I think the phrase that was used earlier was this idea of winging it. I can pretty much confirm that we've been winging it for 34 years. That seems to be the principal tactic. And in some ways, that's a huge commentary back on the system. We shouldn't be winging it. Community organisations like ours up and down the country should get core funding to run their organisations and do what we need to do. But winging it also means that you can be radical and you can be innovative. And so the benefit, if we were to get to a point where we can be core funded, is that so much more would happen. The multiplying effect of the work of places like the Bromley by Bow Centre would be huge in our communities and in our society. So there is, in all of this, a word of caution, a sobering tone in what we're saying, which is we will celebrate all that we're doing, all that our communities are achieving, all that our amazing and remarkable staff team are achieving, all of the things we're doing through the amazing partnerships. And I should say in this call, we also have a number of our funders, people who've been enormously generous to us, organizations that have been generous to us, and individuals as well. And we would not be here today making any of these presentations if it wasn't for those partnerships and the generosity that people have shown towards us. But there is something for us about how we move forward positively. And I think one of the things that's been driving us over the years is a really optimistic view of the world. And even in these dark times, as hopefully we demonstrated this morning, we've been massively creative and determined to change and to adapt and to take on what some have described as this kind of hybrid model as we move forward. But in any workshop like this, I think it's really important that we provoke a response. And this audience is amazingly diverse, coming from lots of different backgrounds. And I hope that if you are representing a community organization like ourselves, I hope you've found some encouragement in what we've said this morning. But I'm really conscious that we learn mutually. And over the years, we've learned so much about what we do and how we do it better from other organizations in other parts of the country who are facing some of the same challenges. If you're working in a field where you think you can help us and our sector to amplify our voice, we'd be really keen to hear from you. If you work in policy and you feel that some of these little nuggets of information, that particularly those that have come from the ground up, from the grassroots team, if some of these could be influential and help shape policy moving forward, and again, we'd be really keen to hear from you. And inevitably, as Chief Executive of a charity, if any of you are funders, or if any of you have any thoughts or ideas or routes to market in terms of funding, particularly unrestricted funding, ways in which we can underpin our model in order to create the working capital that enables us to grow and develop our work, and also share it more widely. One of our clear passions is to share the blueprint, to share from the lessons that we've learned, to reflect and learn from the things that we've got wrong, because it's not a universally positive story. We have got things wrong over the years, and we are discovering new things all the time. But if you know of anyone who you think can help us and support us in funding terms, then please do get in touch. I think email addresses will pop up in the chat, but please do get in touch with me, and I'd be really happy to chat to you. So I think we're going to go into Q&A, and then we've got a bit of a wrap up at the end as well. But I'm going to hand over, hand back to Catherine Rose for the Q&A session.
Thanks, Rob. That was an excellent summary of the conversation, and also that call to action. So we're going to invite the rest of the speakers here. I think we, unfortunately, we may not have Ajit Lalani for this Q&A, but he was with us, I think, for as long as he was able to, given his other priorities. Really pleased to have our speakers back. So I think I'm just actually going to take, there's a few questions that'll come to, but just thinking about, Ajit gave us this really excellent kind of provocation at the beginning and a hypothesis. He was asking whether, is it communities that make the difference? And I think we've talked about that in lots of different ways today, in communities of different kinds. But I wondered if you had any reflections on that hypothesis that Ajit posed. Yes, Emma.
So the question is, do communities make the difference? Yeah, I think one of the things that Layla and Jess and I have been talking about with various degrees of passion over the last few months is about kind of putting the power back in the hands of, well, not even back, because frankly, it hasn't been there for a long time where it should be. And I think that in so many different ways, in different presentations and in different opportunities over the last few months, actually the people that should have been speaking or represented at certain things have not been not necessarily the right people, but they just the voice of the community hasn't been there. But I think what what we reflected on as well, you know, like mutual aid, for example, a completely unfunded, community organized platform of support was actually like the biggest lifeline for our work throughout the pandemic. And I think if that doesn't answer the question about if communities can solve the problem, then I think, yeah, I think that's the best example, because yeah, the power really is when people get together and make their own decisions and are supported to do that, and not kind of, I think it's been mentioned in the chat a lot, not being done to, not being told what to do, but actually just like a desperate understanding of people's situations, and to then help, yeah, to help the situation to change. But yeah.
I would like to add, Catherine, just to basically reiterate what Emma's saying. Completely agree, it is in the hands of the community, and we've relied so much, as Emma said, on grassroots community organisations that have kind of just sprung up off the back of the pandemic. And whilst I'm a great champion for communities getting together and mobilising, I also think that, like, when we think about health inequalities, some of these things are very structural. And as much as mobilising the community, we also need to kind of influence those in power, such as governments, to change some of these structural barriers that are in the way and that kind of widen the inequalities and disproportionately affect a lot of members of our community. So yeah, yay for the community, but also apply pressure.
So well put. Thank you, Layla. I think that's absolutely right. And I think we have it, you know, we're trying to hold both, aren't we, in this conversation, those structural inequalities and where we have agency. There is a question, I think, following on from Rob's comments there, from Simon Rippin. Could Rob or others comment on why core funding for the BBB model isn't present in our system? Is it a symptom of political leaning in England, or is it a symptom from something else? Just wonder, maybe Rob, Julia, do you have any reflections on that together?
Yeah, I've got quite a lot of reflections in that. It's something that exercises us an awful lot. I mean, clearly the system, as it's developed in over the years, and particularly I suspect with, but it's true for both small community organisations, but also for larger community anchor organisations, that as they've grown and developed over a period of time and as the funding's improved, there's been a kind of working assumption from the statutory sector, both locally and nationally, that they will be there, that this hybrid of funding that they've you know, crazily created of, in our case, 60 different funding streams, dancing to lots of different tunes, constantly shifting and changing. You know, the victims in many ways being the frontline staff who work in incredibly difficult circumstances where they're working on short-term fixed-term contracts, you know, are incredibly constant and loyal, but nonetheless, it's a terrible context to be working in. There's just an assumption that will carry on, and I think over this last year we've discovered that actually some organisations can't go on, and of course there is a dilemma here, because on the one hand, as Layla and others have said, and as Emma was mentioning, the mutual aid community is enormously important. I mean, that's brought to the fore. If this doesn't prove it, what will prove it? I think in our lifetime we won't ever see a kind of the creation of a community response in the way that we have over the last year. But of course, that can easily become an excuse for government. I mean, it's just another version of big society, isn't it? It's just another thing that says, well, if everyone clubs together, we can run the local library. And there's a real danger in all of this, that we do fundamentally, and Layla's absolutely right, we do need to be the people in the front line. You know, if we're going to wait for governments, we'll never get anything done. So we do have to get on with the tasks that are in front of us, and we do need to respond. And that's definitely been our philosophy over the last 30 years. But we also do need to say this isn't good enough. We do need to challenge those working in policy and those working in government, and saying, if we do need to equip teachers and head teachers in schools with an annual budget so that in September they know they've got some money to educate children, why would we not do that for family support? Why would we not do that for employment and training? Why would we not do that in the community services, particularly those that are reaching the most vulnerable in our communities and those who are most unlikely to access those services in any other way? Surely we need government support. Surely we need some core funding to support this kind of work. Of course, that can then be topped up with imaginative partnerships with other funds that come along in order for us to do some of the things that are perhaps seen as less core, nonetheless usually very, very important. But we do need to have a change in the deal that the community sector has dealt.
Thank you, Rob. Really helpful. I think, Julia, I was inviting you in because you've played such an important role over the years and seen the shifts and changes as much as Rob has. Do you have any reflections, I suppose, coming from the position of the kind of NHS health partnership side?
Yes, I think providing core funding for these sorts of services is absolutely critical, particularly in a community like ours. NHS funding, I mean, as we all know, is under enormous pressure, has been for a long time, particularly true of funding in primary care. And we try to be as flexible as we can with the funding that we get to try and support this work. And we're also, we've lucky, there've been many restructurings over time. And so with a lot of our key relationships within the kind of the restructurings have been so very supportive of the kind of work that we're trying to do. But essentially, it is very hard for us to stretch into resourcing the model in the way we'd like it to be resourced. From our perspective, we cannot deliver primary care in a traditional way in a community like ours. It does not achieve the outcomes that we need it to achieve. So actually, the sort of work the Bromley Bow Centre does is absolutely critical to delivering that. And having sources of funding that enable those services to continue, but also that support the partnership around those services, recognising that we all have a different piece of the expertise that we need, and the community is a critical part of that as well, and how we make that work as a kind of a package that's sustainable rather than having things stop and start and change is really important moving forwards.
Thanks, Julia. We're coming close to the end. I was just looking through the questions, and there is something that Hector asked, about kind of COVID funding and what can we learn from that going into the future. And I guess I'm taking that question now to offer to a few of us, which is, the pandemic's not over, but I think we've learned a lot. And I've heard other people ask this question to others. What are the things that we want to carry on? What have we learned that we would want to carry on doing? And is there anything that you would want to stop? And I'm hoping we might get around to all of us, but I'm just going to invite the people who haven't had a chance to speak yet. So maybe Saul, and then Jess and Jenny. What is one thing you'd carry on doing that you've learned through this time?
Actually, interestingly enough, this is exactly what we're talking about at the moment in the GP practice. And now that, we're also talking about it in a wider sense as well within the community. There are definitely things that we want to continue practicing. And that, one of the most important ones is the access that we give to our patients. So previously, like a lot of other GP surgeries, we were stuck in this situation where we only had a certain number of appointments available. And once they'd run out, we'd say to people, phone back the next day, phone back the next day. I'm sure we've all experienced that. And one of the things that we managed to do was change that to give everybody pretty much access within the same day that they wanted to speak to us, or at a stretch the next day for, less urgent stuff. And I think it's been really important to be getting our community kind of on side with that, and realizing that it's not just about, okay, I've been waiting for so long, now I need to offload everything onto you as my doctor. It's more about, okay, I just wanted to ask and check with this. And there's a lot more back and forward communication, which also weirdly enough means that we're able to give people, if they phone up with something really simple, like I have a sore eye, you might spend a minute with them. Whereas if they phone up with something more complicated, like anxiety, depression, mental health problems, chest problems, breathing problems, long COVID, we can say, okay, rather than everybody having a 10-minute slot, you can take 2 minutes because that's all you need and all you want. You can therefore have 20 minutes or half an hour, and you can have even longer if you need it. So it does give us a lot more flexibility, and it kind of feels like we're working a lot better as a team with the community.
Thanks, Saul. That's fantastic. Jess, Jenny, we'll just come to you for quick reflections, if that's okay. I know there's a lot in that, but I just want to give Rob a couple of minutes at the end.
One of the things that I think would be good to continue is going back to that piece around connecting individuals who are experiencing similar kind of problems or things in their lives. Like one of the women I spoke to in a proactive wellbeing call had just given birth to her first child, having relationship problems, become homeless, and she was really worried about how her performance as a mother. And we had this access to this group of women who were mainly mothers, and there was a call out like, how can we support this woman? Can someone give her a call? And just our role to be supporting and fostering those kind of lateral connections. I think that's really important in communities and people realizing that they have resources themselves that can be helpful.
Fantastic. Last word to you, Jenny.
Well, that's a lot of pressure, Catherine Rose. Very briefly, I think it would probably speak to what I mentioned before about the notion of collaboration and that sense of what happens when, what happens in that process of cross-sectoral collaboration. Something changes, and I'm fascinated by that meeting point and intersection when arts and health come together, and continuing to see how that changes and influences the culture within the ENO, but also changes and influences the partners and the people that we're working with. That's it for me. Thank you.
Brilliant. Thanks. So Rob and I guess this is our closing goodbye. I've just been totally delighted to chair this event. It's been a real honor. Bromley by Bow, I think, has had a great impact, certainly on my life personally, and it's a tremendous privilege to be involved in this conversation. So thank you from me, and I'll hand over to Rob now for some final goodbyes.
Gosh, was that 2 hours? We seem to have packed a lot into the 2 hours. So thank you, everybody. I just want to say a few thank yous and just some closing things. First of all, just to say, do get in touch. Do see this as the start of a journey, start of a conversation. We do want to, and I know there's 1 or 2 people in this chat have said, can we talk more about this? And we definitely want to do that. So thank you very much, and do continue to engage. And the old adage, it's always best to do it now. So do drop us an email, rob.trimble@bbbc.org.uk, or the more general one as well, if you want to get in touch. The sooner you do it, that we can be sure that it's going to happen. Can I just say my thank you to the presenters for really thoughtful, insightful, stimulating presentations. Can I say a very big thank you to Catherine Rose for chairing this event so ably and so well. Thank you. Can I say thank you to Berenice, who's made sure this has not been a technical challenge. It seems to have gone incredibly smoothly. I worry enormously about these kind of events, but Berenice has been in the background making sure it all happens. The other person in the background, like the Wizard of Oz, has been Janet, who's kind of orchestrated the whole thing for us from start to finish. She's been like the wizard behind the curtain. So Janet, thank you. You've put a ton of work into this, and we are, I can now guarantee, going to do it all again in September, which I'm sure you'll be delighted to hear at this moment in time. But we do want to make these forums, the Spring Forum, the Autumn Forum, a regular feature of our life. And finally, can I say a very big thank you to all of you. For any of you who've been to the Bromley by Bow Centre, you will know I say this continuously, and I really do mean it. We get so much energy and so much encouragement from meeting with people on site in Bromley by Bow, but also from these kind of events. It is an enormous encouragement. I know some of us, not just at Bromley by Bow, but in many organisations, I'm sure, feel that we're ploughing a very narrow and isolated furrow on our own. And these events, I think, do remind us that actually there are some radical and innovative and energetic and determined and positive and optimistic people out there who share the same goals and the same ambitions as we do. So let's keep motivated. I hope you've got some energy and some positivity from this event, but thank you very much for coming. And we will be in touch in the next few days. It's not the last you'll hear from us, but please do get in touch if you want to follow up any of the themes that we've spoken about this morning. Thanks very much.